Today we are having two eminent speakers with us, Dr. Abdul Samad K. and Dr. Geethu G. Dr. Abdul Samad is Professor of Dermatology at Alappuzha Medical College, and he has worked in many of the medical colleges in Kerala, and is a versatile person who was the first editor of the Kerala Journal of Dermatology, and he has given a lot of lectures and had a lot of publications, and he's a good teacher all the more. And he today will be presenting a very interesting topic, that is the biologicals and small molecules in the treatment of psoriasis. So I hope this will be a good help for those who are intending to use biologicals, as well as those who are preparing for examinations. Over to you, Dr. Samad.
Thank you, sir. Am I Naveen Kumar? Am I audible to everyone? Okay. Thank you very much. I am going to, first of all, I express my gratitude to Crichton sir and West Pharma. Actually, this talk was scheduled a little while ago, but unfortunately, I could not make it on that day. So first of all, I apologize to Crichton sir and West Pharma for that lapse on that particular day. Again, I'm very happy that you have, sir, has invited me again for this particular topic. This is one of my favorite topics, that is the recent advances in the management of psoriasis. And luckily, I have got this opportunity to present it before you. Can I share the slide now? Is it correct? Is it visible?
Visible. It is visible. It is visible.
Okay. Okay. Thank you very much. If there is any interruption in the slide, please indicate it to me so that I can rectify it from my side. And a very good morning to all of you, all those who are viewing this particular session. First of all, I congratulate Crichton sir for his initiative. Like all the time, even before, actually, I know Crichton sir for more than 3 decades, for such a committed and enthusiastic person in the field of academics in dermatology. I appreciate you, sir, for your endeavors in the field of teaching. And I thank you once again for giving me this opportunity. And I welcome all the listeners to this particular topic. What I'm intending by this talk is just to give an overview of both the topics, that is the biologicals as well as the small molecules, which have come to the field of treatment of treatment-resistant forms of psoriasis, or in fact, severe forms of psoriasis. And even now, many people are afraid to start, or they are reluctant to start on these newer agents. So for the benefit of all of us, even I have got the opportunity to read more and more about this particular topic, the recent agents or the most advanced agents that we can use in the treatment of psoriasis. First of all, I recall you all to this particular scenario that we have a lot of patients in whom the management has become really a challenge to all of us. So there are many challenging aspects in the management of psoriasis. We are using a lot of products which have been accepted in the forms of or even recommended in the treatment of psoriasis. But many a time we can see that such agents become unsuitable for managing a particular patient, especially a patient who is coming to us with the severe forms of psoriasis, various types of psoriasis, not only plaque psoriasis, different forms of severe forms of psoriasis. We may be confused as to what treatment we have to give further for that patient in order to induce a remission and for to sustaining that remission in such patients. So what are the challenges that we face in treating psoriasis? We have a lot of challenges in front of us. The first is that the available treatment methods which are available today are having many drawbacks. And the second thing is that long treatment becomes very expensive and cumbersome. And most often we see that many patients forego treatment. Even if you are enthusiastically treat such patients, they may forego our treatment and may resort to other forms of other systems of medicines in order to get with the intention of getting a satisfactory remission. We too have, though we have a lot of treatment agencies, in general, we can say that we have very little treatment options in the case of a very severe form of psoriasis. And many comorbidities that patients are having may restrict us in using certain products. So in this context, we have to resort to the most advanced forms of treatment that we have today. The first group of agents are the biologicals, and the second are the small molecules, which are nowadays being given for resistant forms of psoriasis. First of all, just before going to these two agents, first of all, we see what are the contexts in which we resort to these two groups of products, biologics and small molecules. The biological agents in psoriasis, there are too many in number in the current era. And before going to that, we can just go through very briefly through the immunopathogenesis of psoriasis. We know that the activation of the lymphocytes is the most important thing that we can see here. The activated T lymphocytes that will lead on to accumulation of neutrophils, or what is called as neutrophilic chemotaxis, through the mediation of many agents and certain intercellular adhesion molecules that all lead to the process of inflammation occurring in the skin. And this, when it is very wide, that makes the create a real problem for all of us. So we have a lot of pathways how these inflammatory mediators are acting, and at what all levels we can intervene. This is what is meant by this picture. And just to, I'm not going into the details of that. So many products are there which may interfere with the propagation of the inflammation that is happening in psoriasis. The most important thing, one of the initiators of the inflammatory process is the molecule that we all know, that is the tumor necrosis factor alpha. And coming next are the kinds of interleukins which are generated from different kinds of activated T lymphocytes. The most important of these two are the pathways, that is interleukin 12-23 pathway. Actually, the interleukin 23 is a very key molecule or a key substance that is involved in the pathogenesis of psoriasis. Just got a heterodimeric cytokine, that is P19 and P40 subunits. These are the real culprits in the initiation of the inflammatory process. And this in turn leads on to the activation of the Th17 cells that also create a lot of or secrete a lot of cytokines. Of this, the interleukin 17A is the most potent agent that is mediating the inflammation. So ultimately, it is the interleukin 23, interleukin 17 immune axis that is acting in the inflammatory process occurring in psoriasis. So if we have to target this particular things, that is the interleukin 12-23 pathway and interleukin 17, which ultimately leads on to the inflammation in psoriasis. So finally, what happens is that when this go in a relentless way, there is a propagation of the immunological cascade. Before going to the biologic agents proper, first of all, let us see what are the biologic agents or why the biologic agents are being used in the case of psoriasis. We know that we have a lot of conventional systemic agents which is being widely used in the current day practice. They are methotrexate, acitretin, and cyclosporin. These three molecules are mainly resorted to by most of the practicing dermatologists in managing a moderate to severe case of psoriasis. But the problem with these agents is that the use of these drugs over a prolonged period of time produces an end organ damage. For example, methotrexate targets the liver and the lungs. Acitretin targets the liver enzymes, cyclosporin, kidneys, the electrolyte imbalance, everything. So on a long-term basis, this use of these drugs becomes very, poses a challenge for many of the patients. So in this context, biologics become very useful. So what is the advantage of biologics? Biologic therapies utilize molecules that are designed to block specific molecular steps that is important in the pathogenesis of psoriasis. So we have today several biologic agents which are targeting individual cytokines and individual cellular factors which may curtail the inflammatory process that is happening in psoriasis. So some comparative studies between the non-biologic systemic agents as well as the biologic agents, it has been generally seen that about if you are using methotrexate as a treatment agent that has produced, this is based on a very big comparative study, that is at 12 weeks, 12 to 16 weeks, the PASI 75 rates will be about 45% in the case of methotrexate, when in general to the biologic agents it is 63 to 83%. So this itself reveals the fact that how the biologics are working in preventing the inflammatory process occurring in psoriasis. So let us go through other indications. What are the other indications? So the main indication that is put forward for the biology is the rule of 10. That is severe disease that is which has got a PASI score of more than 10 or a body surface area of more than 10% where PASI is not applicable, and a dermatology life quality index of more than 10. So when all these three important factors are above 10, we naturally resort to biologics. But in exceptional circumstances, we can use this even if when this 10 factors less than this particular cutoff value, we can use biologics, especially when there are a very marked inflammation occurring in the lesions and very extensive lesion that actually goes beyond the limit of more than 10% of the body surface area. But consider certain sites where the psoriasis is affected that may prevent a person to come out to the society and work well with their routine duties. That is psoriasis occurring on the face, the genital crural areas, that is very distressing to such patients, and the palmoplantar areas, because palms and soles we are using daily for our routine work. When we have to go, whether it's a manual worker, whether it's an executive, recurrent lesions occurring in these sites will be very much desperate, matter of desperate for the such patients. So we can use biologics on such instances also. The other indications include when phototherapy or other alternative standard systemic therapy are contraindicated, it cannot be used in the in the continuation of such modalities, and many drugs and their related toxicity. When a patient becomes intolerant to a standard systemic therapy, and when they become unresponsive to a systemic therapy, may be very useful, but the particular patient may be unresponsive to a particular time-tested agent. And one of the important things is that when the patients are having coexistent unrelated comorbidities, especially that may prevent us from using certain drugs. For example, liver toxins in the case of methotrexate and acitretin or other retinoid compounds, and renal involvement or electrolyte abnormalities, hypertension, etc. in the case of cyclosporin, like that. And also when they have very severe unstable life-threatening diseases. These are the main indications where we can use biologics. So let us go through the evolution of biologics in the field of treatment history of psoriasis. Probably the first compound that has come to the in our picture, that is as the first biologic that has been used in the treatment of psoriasis was alifacept, which was later on followed by efalisumab. These two compounds were the initiators in the field of biologic therapy in psoriasis, but they became approved in 2003, both the drugs, but soon both these drugs faced some problem. That is, alifacept did not have much of a toxicity, only the toxicity related to the other biologics. But the problem was that there were, with the advent of more efficacious drugs, efficacious biologic agents, alifacept actually vanished from this field of biologic therapy. But the problem with the efalisumab was that it was also approved in 2003, but it was withdrawn in 2009. The problem was that it produced a very serious CNS side effect that was progressive multifocal leukoencephalopathy. So with the detection of this particular serious CNS side effect, efalisumab was also withdrawn from this treatment for psoriasis. And still later came three main agents. This actually marked the biologic efficacy was actually proved in front of the universe, that these three drugs were very effective in treating many cases of severe forms of psoriasis, like etanercept, infliximab, and adalimumab. Still, they continue their uninterrupted reign in the field of psoriasis treatment because all these three drugs are currently in vogue. They're also used by many treating physicians. Etanercept was approved in 2004, both for plaque psoriasis as well as psoriatic arthritis. Infliximab was also like that. It was approved in 2006, and adalimumab in 2008. All the three drugs were very useful for psoriatic arthritis as well. But personally, I would say of all the three, I would prefer adalimumab in the treatment of psoriatic arthritis. We have experienced very good response of psoriatic arthritis. Even the ACR scoring system also has showed very much improvement in the treatment of psoriatic arthritis with adalimumab. So all these three drugs were very useful. That was before the era of 2010. But after 2010, what happened was that there was the advent of a very important drug that was ustekinumab. This actually stood as the first-line treatment for a long period. Ustekinumab was ustekinumab is actually an interleukin 12-23 axis blocker, mainly targeting its P40 subunit. So it was found to be very efficacious in the management of psoriasis, and that was approved by FDA in 2009, both for plaque psoriasis as well as psoriatic arthritis. That is even still used as one of the frontline agent in the treatment of psoriasis. But soon came the wonder drug that is secukinumab. Secukinumab has marked its own role in the field of in the management of psoriasis because this is the most widely used drug in India now. And all the three remaining drugs, that is secukinumab, ixekizumab, and brodalumab, are the interleukin 17A, the ultimate stimulator of inflammation occurring in psoriasis, blocking the interleukin 17A subunit in the molecule so that they produce an arrest of the inflammatory process by blocking all the effect of the activated T lymphocytes onto the mediators. So secukinumab is currently a widely used drug, especially in India, with the standard dosage schedule of 300 milligram. All the dosage schedules I will mention again once I go with the individual agents. So that was approved in 2015. That's very useful for psoriatic arthritis as well. Whereas coming to the next drug, ixekizumab is currently, we can say that the most efficacious drug that is used internationally. That also is an interleukin 17A inhibitor with a dosage schedule as shown here. That was approved in 2016, and that also is a wonderful drug in the management of psoriatic arthritis. And brodalumab is another interleukin 17A receptor blocker that was also approved in 2017, very useful for psoriatic arthritis. So all these three drugs, the interleukin 17A inhibitors, are currently can be considered as the most efficacious. Or if you are selecting a particular agent that is useful for psoriasis management in the present era, I would say secukinumab can be chosen as the one drug that is very useful. It is getting proved that this is a wonder drug that is producing marked effect in the induction of remission as well as the sustainment of remission in many cases of psoriasis. Now coming to the most recent agents which have been introduced, that actually at this point of time, these are the drugs which are found to be the recent entries in the field of biologic treatment in the case of psoriasis. The three drugs, risankizumab, tildrakizumab, and guselkumab, they are internationally used. They have been accepted from in the year 2019, 18, and 17 respectively. Of this, risankizumab has got a very good role because it has got a long-term efficacy, much superior to the other two agents. All are interleukin 23 blockers. And the dosage schedule is as given here. It is 150 milligram. I have shown it only for risankizumab. All the others are having dosage schedule, but I am not concentrating on this drug because currently not available in India. So we will risankizumab also has not been. I think there are some centers who are using that, but mainly it is a drug widely used in the USA and the European Union. Now coming to the next drug, that is a drug which is currently being started using in India. That is certolizumab pegol. Pegol actually stands for the phosphorylated ester form. Actually, it is the polyethylene glycol incorporated certolizumab molecule. The importance of polyethylene glycol when incorporated to certain drugs, the advantage is that they can extend the half-life of this particular drug, so that they become longer active. So certolizumab pegol is a drug that it is available as Cimzia in India, and this was approved by FDA in 2018, both for plaque psoriasis and psoriatic arthritis. And itolizumab is a drug. It is not an interleukin 17 or 23 or 17 blocker. It's an anti-CD6, because you know that anti-CD6 is the CD6 subset of T lymphocytes releases the interleukin 6, so that is a blocker of itolizumab. The ultimate most potent interleukin that is producing an inflammation psoriasis other than interleukin 17 is interleukin 6. So itolizumab has got a role in the management because it's an anti-CD6 monoclonal antibody. It is available as 25 milligram vials in 5 ml. That also is used. It has been approved by. It's used in India by the Drug Controller General of India in 2013. Now coming to, these are the main biologics because that I have to mention. There are a few more biologics are there in the field, but I'm not going into that because so many of them are in the trial stage. Many of them are not being very well accepted by all the practitioners in all over the world. Now let us go through what are the target-based classification of. This is mainly for academic purpose. For the practitioners also it's important because naturally we will go for interleukin 17 blockers. So we have to know which are the drugs which are acting through which all ways. The TNF alpha inhibitors are infliximab, adalimumab, golimumab. Now it's not very widely used anywhere. But certolizumab pegol and etanercept are still two drugs which are very useful TNF alpha inhibitors. In fact, adalimumab, in my institution, adalimumab is the drug that we are giving for psoriasis and psoriatic arthritis. It's also a very good drug because we are getting very good PASI 75 and PASI 90 responses in patients being treated with adalimumab. The interleukin 12-23 inhibitor used you'll say that the ex-king of the biologic therapy in India from 2008 to 2015. This was considered as a wonder drug. This was widely used all over the world, and that produces very good efficacy in the management of severe psoriasis. But the current day's treatment will be the interleukin 23 inhibitors and interleukin 17 inhibitors. Of or I have mentioned the interleukin 23 inhibitors are guselkumab, risankizumab, tildrakizumab, and mirikizumab. But the last two are not approved. Actually, the other two are being approved by US FDA. Then the interleukin 17 inhibitors, the most efficacious class of drugs which are used in the management of psoriasis as of now. That includes secukinumab, ixekizumab, brodalumab. These three drugs are currently in vogue, but bimekizumab, it's a very good drug, but that's not approved. And one more drug that is used in the another category, that is a cytotoxic T lymphocyte associated antigen for immunoglobulin fusion molecule, that is abatacept. This was a drug which was used in the 2012 to 15 period, but later not much of reports are there pertaining to this drug, but very good agent for treating psoriatic arthritis. Now we can go to I think I don't know. If I am exceeding time, please indicate so that I can cut short the description about this drug. Crichton sir, I go this speed. I may have about 15 or 20 slides more.
Yeah, okay, go ahead. Go ahead.
Okay. So I'll quickly go through because already it is 12 o'clock. So I'll go through all the other agents. Infliximab was the first effective drug that is considered in the treatment of psoriasis. Since after its inception, it was considered to be a very good drug. It is a tumor necrosis factor alpha inhibitor. I'll go with the dosage schedule of each drug because all the other things have been mentioned in the general aspects. Infliximab is available as 200 milligram vials. So dosage is 5 milligram per kilogram. At week 3, schedules are given as the first initiating dose. At week 0, 0, 2, and 6. That is 2 weeks apart, and after that 4 weeks. So that will control the activity of psoriasis in most of the instances. And if at all you want it to continue, you can give it a 4th dose at 12 weeks. And with that, after that, at 8 weeks interval, you can assess the severity of the disease, and we can give a booster-like dosages in between. Once in 8 weeks or once in 12 weeks, you can give as booster doses. But in most of the instances, many reports show that the first 3 doses itself is able to control the disease activity, that is 0, 2, and 6. Coming to etanercept, etanercept is considered as, it is the second most widely used drug in India. Very good inducer of remission. It is second to secukinumab in its usage in India. It is indicated in moderate to severe psoriasis and more moderate to severe forms of psoriatic arthritis as well. The dosage schedule that is recommended is 50 milligram twice weekly for the first 2 weeks. That is, first 2 weeks you give 50 milligram. If you are giving on Monday, you can give it, repeat it on Thursday after 3 or 4 days. Give the same dosage next week also. That is, first 2 weeks, it is 50 milligram subcutaneous for 2 weeks. Then you can continue it as 25 milligram twice weekly for another 10 weeks. So total, it will be a 12 weeks regimen for etanercept, widely available as M.B.B.S, marketed by White in India. It's also a very good drug. Its advantage is that it's a good drug that is proved to be useful when used along with the methotrexate. It produces very good remission. I have the personal experience of giving etanercept for psoriatic arthritis patient, and that too when used along with either Apremilast or methotrexate, it produces very good effect for induction of remission. Coming to secukinumab, the most widely used biologic in India. In a survey recently in India, have shown that nearly 70% of the dermatologists prefer secukinumab as their drug of choice as far as the biologics are concerned. Secukinumab is indicated in moderate to severe plaque psoriasis and psoriatic arthritis. It's a recombinant high-affinity fully human immunoglobulin G1 kappa monoclonal antibody that is targeting the interleukin 17A. Its dosage schedule is that it's available as 150 milligram per ml vials. So you can preloaded syringes, and we can use 300 milligram, that is 2 subcutaneous injection on week 0, then 1, 2, and 3. That is 4 weeks consecutively. You can give 300 milligram as a subcutaneous dosage. And after that, on most of the occasion, this produces a very good remission. But from 4th week onwards, you can give another injection at the 4th week, week 4, that is on the 5th week. Then after that, at 4 weekly intervals, till you are getting a desired remission. But often this is not necessary. What we have observed is that it produces very good remission with the 4 injections of secukinumab. More than 80% of the patient attain PASI 75 week. Also, that's a very good response. Then coming to adalimumab, adalimumab is previously projected as a drug very useful for psoriatic arthritis, but we have observed that adalimumab, in our institution, adalimumab is the only biologic that they are allowed to use under our insurance program. So we are using a lot of cases, adalimumab in a lot of cases of psoriatic arthritis, psoriasis as well as arthritis, and we are getting very good response. It is an IgG1 monoclonal antibody. It is targeting the tumor necrosis factor, and that regulates the tumor necrosis factor induced biological responses. And in general, it is in that PASI 75 better achieved in 53% and 80% in an observational study. And very important side effect is that many biologics have the side effects of reactivation of tuberculosis and hepatitis. But apart from that, we have observed high hypertriglyceridemia also in many patients treated with adalimumab. It is the reported side effect of adalimumab. Now come to ustekinumab. Ustekinumab use is very restricted in India, but in international papers, if you refer, it is seen that ustekinumab is still the preferred drug in many centers worldwide. So it's an interleukin 12-23 inhibitor, and it is considered as a first-line biologic agent. And it targets a P40 subunits of the interleukins, interleukin 12 and 23. We know that interleukin 12 and 23 act together. And it is a preclude for activation of the interleukin 17, so that you can block interleukin 17 also if you are blocking interleukin 12 and 23 in the pathway. So the efficacy in various studies, it's found that it is just inferior to secukinumab, but we can see that the 75% improvement in the PASI 75, in about 67% of the patients at week 16 indicates that it's a very good agent for inducing remission and sustaining it. And many comparative studies have shown that it is much superior to TNF alpha blockers. But it has got, the ustekinumab has got some more side effects like that. It produces nasopharyngitis, pulpovaginal candidias, and other mycotic infections, especially extensive tinea corporis, is one of the side effects that is noticed after the usage of ustekinumab. Then bronchitis, pruritus, UTI, sinusitis, all these are encountered in patients being treated with ustekinumab. And brodalumab also, it's a very wonderful drug that is used in, as it's a human interleukin 17 receptor monoclonal antibody, and many comparative studies have shown that it has got a very good efficacy over other agents. Better passive response at 12 weeks have been shown by brodalumab also. Now coming to the other drugs, ixekizumab is also a wonder. Ixekizumab currently is considered as the most efficacious interleukin 17 inhibitor, and in the ixekizumab is, it is mainly used at the international level only, and its PASI 75 response is seen in about 90% of the patients, and PASI 100 response is seen in 40%. That's a very remarkable efficacy of ixekizumab. But the problem with ixekizumab that it has got suicidal ideations and behavioral abnormalities. So better you have to choose patients who are vulnerable to this side. You have to avoid patients with these side effects. Abatacept, it's not a much projected drug because it is a cytotoxic T lymphocyte associated antigen for blocker drug. So that actually this it's a co-stimulatory signal for CD28. So it's mainly projected as a drug that is used in the treatment of psoriatic arthritis. Certolizumab Pegol is Cimzia, is a drug that is used in India. It is the only FC-free pegylated, that is the polyethylene glycol incorporated drug that is used in the treatment of psoriasis. That is, it has got also very good PASI 100 response. And the side effects of certolizumab, so some side effect that is pertaining to certolizumab is its elevation in blood pressure. These are the three recent agents: risankizumab, tildrakizumab, and guselkumab. These are the most important agents which are in the current scenario. These are drugs which are widely used, and all are humanized IgG1 blockers, which blocks interleukin 23. That is the target, the P19 subunits. All are used to be. I'm not going to the dosage because it has not come to India as of now. So very soon it will be there in the field of psoriasis management in our country also. Now, this is a web-based network meta-analysis of various agents that is used in the field of, this came in 2021. We can see which all drugs are currently the most efficacious drugs in the field of psoriasis management. So I would say that ixekizumab has come as the topmost agent with a 72.9% PASI 90 response. And in terms of SUCRA, that is, SUCRA is a statistical tool for assessing drug used in the field of drug efficacy comparison. That is a surface under cumulative ranking curve. It has got a better score for ixekizumab. Then it is followed by risankizumab and brodalumab. So if a question is asked which are the most efficacious drug, based on the scientific data, we can say that ixekizumab is risankizumab and brodalumab are the most efficacious agents. But risankizumab has got a higher long-term efficacy also. Now, to summarize on biologics, I would say that the various biologics under different classes are there. Mainly they come under the TNF alpha inhibitors, interleukin 12 and 23 inhibitors, interleukin 23 P19 inhibitors, and interleukin 17 inhibitors. These are the four major classes of biologics which are currently available. And the second fact that the cumulative toxicity and end organ damage by other drugs that we use routinely in our practice put biologics as the treatment of choice in moderately severe and severe types of psoriasis and psoriatic arthritis. And of late, interleukin 17A inhibitors and interleukin 23 P19 humanized monoclonal antibodies are the two classes of drugs which are the most efficacious biologics in the present time. Secukinumab is the most widely used one in India, and ixekizumab and risankizumab are the most scientifically proved most efficacious agents. So that is all what I have. I like to project on biologics. These are what I have said are only tips of iceberg. you can expand your knowledge by further reading from our literature. Now, coming to the second part of it, I'll quickly go through that, the small molecules in the management of psoriasis. We know that in the etiopathogenesis of psoriasis, we have a lot of pathways which actually lead on to the pro-inflammatory gene transcription. I'll just go through this, this important pathways. One is the nuclear factor kappa B pathway. This is actually induced by the protein kinase C. That is, the diacylglycerol is the substrate for that, generating this particular pathway, and it is incorporated acting in conjunction with the protein kinase C. So this is one target by which you can use a small molecule in arresting the progression of, or actually the pro-inflammatory gene transcription can be blocked by using certain drugs. One important drug is sotrastorin, which has not been come into the field of treatment so far, but it's a drug that is now widely used in transplant rejection. The next is the pathway where phosphodiesterase 4 is acting, and that converts the cyclic form of AMP to the non-cyclic AMP. Non-cyclic AMP is a potent mediator of inflammation, whereas cyclic AMP is actually a regulatory factor in that. So that what we like is to accumulate cyclic AMP in the tissues so that its conversion to AMP must be prevented in order to prevent inflammatory process in psoriasis. So this PDE4 enzyme is the culprit there. So our aim should be to block this particular drug. That is, it is with the help of Apremilast. That's another promising small molecule in that. The next is the JAK-STAT inhibitors. We know that JAK-STAT is a pathway where Janus Kinase acts in together with the signal transducers and activators of transcription. That is, the JAK-STAT pathway produces inflammatory process. The STAT, when accumulated, that also is a pro-inflammatory gene transcription stimulator. So we have to block this particular pathway. That is the JAK-STAT pathway. That has been done by a variety of agents that I'll come to that later. And the fourth one is the P38 pathway, which also a tumor necrosis factor alpha mediated one that leads on to the stimulation of the pro-inflammatory gene transcription. That is blocked by the dinsinosoids and anisomoids. And dinsinosoids are not in the field of psoriasis treatment. It is mainly in the anti-tumor therapy, whereas anisomycin has got some prospective role. So when we talk about the small molecules as the treatment agents in blocking the pro-inflammatory cytokines, two major drugs are there. One is the phosphodiesterase 4 inhibitor that I have said. This is the Apremilast. And the next is the Janus Kinase inhibitors. These two groups of drugs must be considered as the most efficacious small molecules in the field of psoriasis. And the other agents are also there, the fumaric acid esters, amygdalin analogs, protein kinase C inhibitors, mitogen activated protein kinase C inhibitors, etc. I'm not going to the details of that because of the time constraints. I'll just concentrate on the phosphodiesterase 4 inhibitors. FDE, the phosphodiesterase inhibitor 4, is a family of enzymes that regulate the intracellular levels of cyclic nucleotides, that is the non-cyclic form of adenosine monophosphate, which are potent mediators of inflammation. So we have to increase the dose of cyclic AMP in the tissue. So by blocking the enzyme, this we can assume, we can attain that the cyclic AMP will check the inflammatory response by many of the inflammatory agents. So the PDE4 inhibitors approved for the treatment of inflammatory disorders in psoriasis are three molecules: roflumilast, apremilast, and crisaborole. Of this, apremilast is currently in the field, actively in the field of managing psoriasis. Crisaborole, we know that it is used as a topical agent in atopic dermatitis. And in the skin, PDE4 is principally expressed in many cells, and the inhibition of PDE will increase the intracellular level of cyclic AMP so that the inflammation can be stopped. And apremilast, it alleviates the epidermal thickness. Clinically, it will produce decrease abnormal proliferation and reduces the expression of TNF alpha, HLA-DR, and ICAM1. And it is used by US FDA to moderate to severe psoriasis in 2014. And clinically, we can see efficacy of this both in plaque psoriasis and psoriatic arthritis. So apremilast we are all using in the current situation. It is known that we can know that in plaque psoriasis, it has got more than 75% response in 20% of the patient. The peculiarity of Apremilast is that you have to give some time for Apremilast to act. Don't misjudge Apremilast by seeing a 2 or 3 weeks response. You have to wait for a little more time because it can exert its effects only with a little time. Then only we can assess the efficacy of that. Even after 8 to 10 weeks, or even after 2 or 3 months, you are not seeing any response, you can discard it as a form of treatment for that particular patient. And two advantages of this is that in certain situations, peculiar types of psoriasis, that is nail psoriasis and scalp psoriasis, it has got very tremendous effect. And in psoriatic arthritis also, it works very well. And we know that we start with a low dose because of the gastritis associated with that. We have to adopt a stepwise increase in the management. You can give 10 milligram 2 times a day initially, then you can step it up to 20 milligram. And finally, the final dose will be 30 milligram twice daily. And just I am drawing your kind attention to a web-based questionnaire study by Muralidhar Rajagopal in 2021 that certain things have been revealed about Apremilast. That is, it's effective and stable to mild moderate psoriasis as monotherapy, and it's a combination in severe types of psoriasis. It is very useful in difficult situations like scalp psoriasis, palmoplantar psoriasis, nail psoriasis. And therapy should be continued for a minimum of 8 weeks once it is initiated. And you can give a little more time. Total duration of therapy can be up to 24 weeks before discarding it as an efficacious treatment. And it is very effective for, you can choose patients for Apremilast, that is patients with hepatitis B or C, obese patients, or patients on polypharmacy, because there's not much of drug interaction with this drug. Main side effects are nausea, vomiting, headache, cold-like symptoms. The next group is the Janus Kinase inhibitors. The Janus Kinase signal transducer and activator of transcription. The JAK-STAT pathway is an important pathway in the gene transcription of inflammatory mediators. So it has it can block the intracellular signaling cytokines. There are several families of JAK-STAT inhibitors. Of this, important one are JAK1, 2, 3, and TYK2. And they have got very important role in the mediators of inflammation, mainly interleukin-6 and the epidermal growth factor. It has got tremendous effect. So by blocking this pathway, you can attain a remission, and you can continue that in many patients. As of now, the main drugs used are tofacitinib, ruxolitinib, and baricitinib. These are the first generation because they block multiple Janus kinase, whereas the second generation cytokine will be soon readily available in the market that blocks only one type of Janus kinase, that is, and the molecules are dasatinib and filgotinib. And tofacitinib is one of the potent agents that, especially in psoriatic arthritis, it has proved its efficacy in rheumatoid arthritis. But I have given tofacitinib for a few patients, but I didn't get any tremendous effect on that. But I have modest response in many patients with the psoriatic arthritis. It was approved in rheumatoid arthritis in November 2012, and for psoriatic arthritis in 2017. And it actually it blocks, normalizes the interleukin-23-17 axis. The adult dose is 5 milligram orally twice daily, the immediate release tablets, and there's an extended release tablet of 11 milligram that is sufficient as a once daily therapy. And I'm skipping all other agents because I have too much. I have exceeded the time. Fumaric acid dimethyl fumarate is one of the agents that has been recently approved, and that has got a very important role in the management of psoriasis. And the amygdalin analogs, the one protein kinase C inhibitors, also form very important group of drugs. So if it's sotrastatin, in future, I am sure that this will be a promising drug because that inhibits protein kinase C, and NFK kappa B pathway will be blocked, and that will be a very good. Currently, it is very useful agent for transplant rejection. And the mitogen activated protein kinase inhibitor, anisomycin, it has a drug having multi-spectrum activity. Spleen kinase protein inhibitors are also will be there in that. So finally, just a comment about what is the future in the psoriasis management. I'd like to comment that biologics and small molecules have proved to be a quantum leap forward in the management of difficult to treat psoriasis. There are so many agents coming up, especially to block the intercellular signaling pathway of interleukin-23 and 17 are the main targets that we aim. And deucravacitinib is a drug which has got promising facts in the management of psoriasis. So both these kinds of molecules, biologics and the small molecules, are valuable additives for the therapeutic armamentarium in psoriasis. Once again, thank you very much for all of you for your kind listening. And once again, I thank Crichton sir and the East West Pharma for giving me this opportunity. Thank you again. I have a few quiz questions. If it is permitted, I'll go with that.
Yeah, go ahead.
Okay. Some quiz questions has been asked to me by Crichton sir that you can put. I have put 5 MCQ questions for the postgraduate students who are viewing this. You can answer to this. Everything is being from this my talk only. I haven't put anything out from outside. So first question is your answer. It's all are multiple choice questions. Only one answer, correct answer will be there. All of the following are TNF alpha inhibitors except the 4 choices are adalimumab, certolizumab, etanercept, and ixekizumab. PGs can please answer. I think Mr. Naveen Kumar will be coordinating.
Yes, doctor.
Okay, you can start answering. All of the following are TNF alpha inhibitors except there will be only one correct answer. You can mention the alphabet and the correct answer along with that. A is adalimumab, B is certolizumab, C is etanercept, D is ixekizumab. Next question. Which of the following is an anti-CD6 monoclonal antibody? Anti-CD6. We have talked about anti-interleukin 12, 23, interleukin 17, tumor necrosis. So which of the following is an anti-CD6 monoclonal antibody? Directly inhibiting anti-CD6. That choice A is brodalumab, choice B is efalizumab, C is guselkumab, D is itolizumab. Which of the following is an anti-CD6 monoclonal antibody? Let me go to question number 3. Which of the following is a pegylated anti-tumor necrosis factor alpha? Which of the following is a pegylated? I mentioned polyethylene glycosylated molecule will enhance the half-life of the drug. So which of the drug is a pegylated incorporated biology? Adalimumab, choice A is adalimumab, choice B is certolizumab, choice C is golimumab, choice D is infliximab. Which of this following is a pegylated anti-tumor necrosis factor alpha in India? I said it is widely available in India. Question number 4. Sotrastorin acts by inhibiting which pathway? A, JAK-STAT pathway, B is PDE4, C, protein kinase C, choice D is TNF alpha. Sotrastorin acts by inhibiting A, JAK-STAT pathway, B is phosphodiesterase E4, protein kinase C, and choice D is TNF alpha. And the last question, anisomycin is an amygdalin analog, fumaric acid ester, JAK-STAT inhibitor, mitogen activated protein kinase inhibitor. Anisomycin. It's an amygdalin analog, B, fumaric acid ester, C is JAK-STAT inhibitor, D is mitogen activated protein kinase inhibitor. So these are my 5 questions. And thank you again for permitting me to present this multiple choice question. Thank you, Crichton. Sir, over to you.
Thank you. Naveen?
Yes, sir.
You have compiled
I'm
the
recording.
answers?
Yes, sir. Yes, sir. I will. Madam will start, sir.
Okay.
We will. Sir.
Thank you, Dr. Samad, for your wonderful talk. And in fact, it gives a very good overview of all the biologicals and small molecules for the treatment of psoriasis. And in fact, this is important for your final year examination. And if you remember this, you can score very high marks in that particular area. And of course, it is useful in practical examination as well. And all the more, if you are going to practice dermatology, this will become a very, very important as a guideline. And of course, you have to build upon, based on this particular talk, on various different biologicals and small molecules, and various other considerations will be there, like the pocket of the patient, as well as the circumstances from where the patient is coming to. All these are very important considerations for the choice of the drug. Anyway, Dr. Samad has done a very beautiful work in this by presenting his talk. And I am grateful to you, Dr. Samad, for your wonderful organization of the talk. Thank you very much.
Thank you.
So the next speaker is Dr. Geethu ji. She is presently working in the government service as a consultant dermatologist. More than that, she's an academic dermatologist. If you go to the curriculum vitae of Dr. Geethu ji, right from the very beginning of her dermatology training, she was very much interested, or rather, she has a bent of academic pursuit. And the evidence could be seen by the fact that she has received the Kerala University of Health Services Young Researcher Award and Dr. B.K.H. Nair Award as a young scientist. So that itself shows that she is academically bent. More than that, and at this young age, she has authored two important text books. One is the monogram on the non-pharmacological management of atopic dermatitis. And there is another book which she has not mentioned in this curriculum vitae, is that dermatology for principles and practice of dermatology for the general practitioners. So that shows the various, the extended interest in dermatology by her. And the third one is yet another difficult area, is she is preparing, in the book is in press, that the dermatology for barefoot doctors. So she is academically very good, and she has a lot of interest in dermatology. And over to you, Dr. Geethu.
Thank you, sir. Good afternoon, one and all. Am I audible?
Yes, ma'am.
Okay.
Thank you, sir. Thank you, sir, for all the kind words. Good afternoon, one and all. Thank Dr. Titan for giving me this opportunity to give this this talk, and also my thanks and appreciation to West Pharma for organizing this webinar series. Now, we'll go into the topic proper. My topic for today is non-pharmacological management of atopic dermatitis. So in this session, I'll be dealing with what is non-pharmacological management, why it should be practiced, and how it should be done. Miss,
Ma'am, your line is.
excuse me, Mr.
Ma'am?
Naveen. I think there is, yeah, thank you. And the,
Yes. Madam, your voice is
Hello?
not clear, ma'am. Your voice is not clear, ma'am.
it's not clear.
And now it is okay, ma'am. You can continue.
Yeah. Development and the progression of atopic dermatitis is driven by several factors. The genetics, epidermal barrier integrity, and also the environmental factors. Thus, with the
Ma'am, you can off your video and you can speak, ma'am. I think your bandwidth is very low.
factors or different players in the field, the successful.
Ma'am?
Okay. Yes, yes.
Yes, ma'am. Ma'am, you can off your video, ma'am. Your bandwidth is very weak, ma'am. Yeah.
Is it okay now?
Yes, ma'am. Yes.
Yes. Okay. So, for the successful management of atopic dermatitis, we have to address all these factors, different factors in the field. So, the treatment of atopic dermatitis should mainly focus on the drugs and also the environmental factors. And I'm just pushing through the pathophysiology of atopic dermatitis. The pHs, allergens, various infections, protein, irritants, all these lead to a micro trauma to the already damaged skin. That is epidermal barrier defects with mutation and or other, all this trauma leads to an immunological cascade downwards. And there has been a lot of discussion going on whether this epidermal barrier integrity dysfunction occurs first or the immunological cascade or the immunological dysfunction occurs first. So whatever that is happening, if it is the first barrier disintegrity leading to the immunological cascade or the immunological cascade leading to the epidermal barrier dysfunction, the main pathological key events are the two factors, immunological dysfunction or the epidermal barrier disintegrity. So in this talk, I am not going much into the immunological cascade of atopic dermatitis, as you all will be well versed about it. I'll be dealing with what are the factors which can be modified without any drugs, the non-pharmacological interventions. Hence, this session deals with the environmental factors, how we can modify the atopic dermatitis, the life of atopic dermatitis without drugs and using the non-pharmacological interventions. So atopic dermatitis management should be an all-encompassing one with both drug therapy and the non-pharmacological intervention, each given its due importance. So, so as to define what are non-pharmacological interventions, these are a set of interventions apart from drugs to alter the progression of the pathological cascade of atopic dermatitis. This should be a complementary treatment, no substitute for pharmacology therapy. This aims at reducing the severity of the illness, reduction of flare,
Ma'am? Ma'am? Your voice is not audible, ma'am.
maintenance of remission, and improvement in quality of life. Further, the slides not audible.
Now it is, madam. In between, we lost your voice, madam.
Yes.
Just tell me, ma'am, which slide we are you right now? Is the same approach to AD management?
Ninth one.
Is this?
Yeah.
Yeah.
Am I audible now?
Yes, ma'am.
Yes. So, as I said, the goals of non-pharmacological management are to reduce the severity, reduction of flare episodes, maintenance of remission, and improvement of quality of life. So, in this section, we'll be dealing with the non-pharmacological interventions under 6 headings. That is educational interventions, moisturizers and barrier repair, wet trap therapy, skin hygiene measures, identification and avoidance of trigger factors, and psychological interventions in atopic dermatitis. Yes, yes. These are the six subsections: educational interventions, moisturizers and barrier repair, wet trap therapy, skin hygiene measures, identification and avoidance of trigger factors, and psychological interventions in atopic dermatitis. Next slide, please. Educational intervention. We'll go into a discussion of each of these sections. Educational intervention is the first and foremost step in the comprehensive care of patients with atopic dermatitis. This helps to have a realistic approach of the disease and its outcome. This should actually start with the first visit to our OPD. We have to assess the patient and estimate the role of educational intervention in a particular patient. Nowadays, most of the patients, majority of the patients coming will have some kind of background information about the disease because they are having the disease for a long time. So we have to assess them and what all information they know. And most of their internet searches, there might be true informations or also some misconceptions or false informations. So we have to assess their background knowledge and educate about the disease and address any misconceptions if they have. Also, this should be an ongoing process, this educational intervention. It should start with the first visit and continue in the following visits. This should help the patient to identify any possible triggers when they are presenting with a flare. And they should also, this will help in managing or avoiding the triggers in further episodes. And thus, in this educational intervention, what we aim is that we have to make an emphasis that that treatment of atopic dermatitis is not just the drugs we prescribe. There is a role from their part, the patient or their caregiver, and they have to take an important initiative or role in the management of atopic dermatitis. How they intervene or how they help in the management, it should be emphasized. So this will build a confidence in the patient. They will also get involved in the management of atopic dermatitis, and this will help to have more patient adherence and also in the follow-up of atopic dermatitis management. This can also be done other than the one-to-one conversation. We can also do this educational intervention through group approaches, workshops, educational videos, pamphlets, and written action plans. A few words about the written action plan. Can you please go to the next slide? A written action plan. This is developed with a purpose of giving some set guidelines to be followed at home. That is, the patient and the caregiver will have a set guidelines that should be followed at home. They will have some do's and don'ts. We have formulated a written action plan that was given in our book. I just have copied it there, not going further into that. And this will build a confidence in the patient, and they'll know what they can do and what they can't do. Can you please go forward in the slides? Yeah, next slide. Next. Yeah, this. I'm not going further into that. These are do's and don'ts, and what are the warning signs of an infected eczema? What are the warning signs of an exacerbation? This we can give it as a print. So this is like this written action plan in atopic dermatitis or in any other chronic condition. It has there are several studies showing it has got improved patient adherence if you are giving such a written action plan. Okay, going into the next section, coming to the moisturizers and barrier repair. These are the primary treatment for, as you all know, in mild atopic dermatitis, and it's also an important adjunct in moderate to severe atopic dermatitis. So what I'm going to discuss is what are the benefits, like what are the common moisturizer, the contents, and what should we practice. Moisturizers and barrier repair formulations, they reduce the pruritus and xerosis by increasing the skin hydration and reducing the TWL. This has also proven to reduce the amount of anti-inflammatory treatments required, and it also reduces the overall disease severity and has a role in prevention of flares. Ceramides and pseudoceramide containing ones has shown as tend to repair the skin barrier also. Now, coming into the ingredients of things include actives and excipients. Actives include the humectants, occlusives, and emollients, and also ceramides. Excipients are the other contents which are present in the moisturizer. Often, the term moisturizer is said synonymously with emollient, but we prefer to use the name moisturizer as in majority of the literature it's mentioned emollient is one content of the moisturizer, one active content of the moisturizer. Now coming to humectants. Next slide, please. Humectants are hygroscopic molecules which attract water from the dermis and the atmosphere, and they hover it into the epidermal layers. NMF, glycerol, propylene glycol, PCA, urea, and lactic acid. These are the common humectants. These are used in combination with occlusives. These occlusives, they prevent the loss of trapped water to the environment. Now coming to the occlusives, these occlusives, common occlusives, next slide please. Common occlusives are liquid paraffin, petroleum, lanolin, mineral oil, silicone derivatives like dimethicone, cyclomethicone, and all. These form a water impermeable layer over the skin and in between corneocytes, retarding evaporation and loss of water. These are often greasy and more effective to the dampened skin. Next are the emollients. Emollients, next slide please. Emollients contribute to the cosmetic elegance by giving a soft and smooth texture skin. These are lipids or oils capable of filling crevices between the fragmented collection of desquamating corneocytes. Nowadays, the moisturization of all the three, the separate ones are also available, especially in women's sector and all, we get liquid paraffin alone. So a combination is more effective actually. And now a special mention made about the newer barrier repair formulations. Next slide, please. Before that, excipients and additives. Additives are the colloidal oatmeal, glycinic acid, aloe vera, other botanicals like vitamin ferracea, butter allantoin, antioxidants, vitamin E, ascorbic acid, chelating agents like vitamins, fragrances, coloring agents, preservatives, and emulsifying agents. Next, about the repair formulations. Next slide, please. Barrier repair formulations, the ceramide and pseudoceramide containing formulations are now widely available in market. That is the scientific basis behind this is that a combination, a optimal molar ratio of 3:1:1 of ceramides, cholesterol, and fatty acid in a concentration of more than 1 to 2%. This can influence the barrier recovery by penetrating into deeper epidermal layer and incorporation into nascent lamellar bodies. This is the this particular combination only this property. All the other moisturizer active, they go only to the corneocyte layer. This can penetrate down and it has got a barrier repair property. So these are the newer ones, recent ones. It's not recent, for past 1 decade it has been there, but it has proven to be useful. Coming to the next slide. Next slide. So how to choose and how to use the moisturizer. how to choose and how to use moisturizer. Actually, the product of the previous slide, please. The product is actually more important than the product is actually the what product you use is not much important, because the way you use is more important. This has to be interested, because you have to use it liberally and frequently as and when the child feels dry and itchy. We recommend to use moisturizer immediately following bathing and soft pad drying. The choice should actually be according to the preference of the patient. Some patients will prefer certain kind of moisturizer, so we can allow them to use that moisturizer, but it should be emphasized that it should be used very frequently. That is one of the things we always miss. You have to talk to them and make them understand. Sometimes in some in these atopic skin, they will become dry after few hours of applying, 1 or 2 hours of applying, so they have to reapply again. And it should be applied just in sufficient enough to smear the skin in the general direction of growth of body hair to prevent folliculitis. Next slide, please. And they should be dispensed in moisturizers should be dispensed with pump dispensers. If it's with a pot or a jar, it should be taken out with a spatula. This is to prevent contamination. In resource poor setting, use of any vegetable oil of local origin may be used, and the patient of patient preference may be used, and this can be used repeatedly. We have to warn about the folliculitis, because it should be applied only in the direction of the hair growth, and they may be all applied to advised to apply the warm vegetable oil for 10 to 15 minutes before bathing, and also frequently thereafter. And that is about the moisturizers. Now coming to the wet wrap therapy. Wet wrap therapy is a treatment modality using double layer of tubular bandages or gauze. The first layer is moist, that is, we have to wrap the body part in a first moist layer of bandage, and then second dry layer is used. This increases the penetration of the topical agent by occlusion, decreasing the transepidermal water loss, and has a soothing effect and provides a physical barrier against scratching. This is considered as a safe short-term intervention in atopic dermatitis. We have got several protocols for wet wrap therapy, and the conventional therapy, please. In the conventional therapy, they use a 3 to 24-hour wet wrap with frequent wetting. But what we follow is a modified wet therapy, that is an amla modification of the normal conventional wet wrap. Next slide, please. In this type of wet wrap therapy, we use a 2-hour wet wrap therapy thrice daily. That is two times a day, which we use wet wrap using mid-potent topical steroid, and another in the midday we use wet wrap with emollient. And the rest of the time of the day, the patient is asked to eat area of frequent application of moisture. Very good result in moderate to severe dermatitis, and it's also recommended as a second line in treatment of moderate to severe atopic dermatitis. Next slide, please. But there has got several limitations for this wet wrap therapy. One, it is time consuming. And also the patient adherence is a problem. Patients, they will have a discomfort when these tubular bandages are applied. Also, there may be a chance of folliculitis is there. So there are some limitations for this wet wrap therapy, but with proper education, with proper encouragement, if this is followed, this will give very beautiful results. Next, coming to the skin hygiene measures. Cleansing and bathing constitutes one of the most important lifestyle interventions. Primary purpose is removal of dirt and grime. It also reduces the quantum of bacteria in the skin, removes the irritants and potent allergens, and prehydrates the skin, thus improving the efficacy of topical therapies. But how frequently they should bath, or what are the duration of bath? There are a lot of studies regarding this, and according to the recent Cochrane analysis, there are different results. That is, not one study has shown a superior result, but we have given some practical recommendations. There are some practical guidelines also. Next slide, please. So ideal cleansing agent is a low pH, hypoallergenic, fragrance-free agent, which is affordable to the patient. Synthets and lipid-free cleansers are, of course, close to ideal in atopic dermatitis, but in a resource-poor setting, we can ask the patient, they may use any cleansing agent unless they shorten the bath time and also the lathering. Any cleansing agent may be used, but they have to use any vegetable oil or any locally available oil before taking bath. This will help to prevent the after bath tightness of the skin. Next slide, please. Next slide, please. In bathing and atopic dermatitis, there are several factors. That is the duration, frequency, hardness, and temperature of the water, type of cleansing agents. As I told, there are conflicting results. But what we recommend is that a 10 to 15 short time of bath, 10 to 15 minute bath. Next slide, please. 10 to 15 minutes of bath, and the bath should be pleasurable for the child. We should always ask them to apply this warmed vegetable oil or warmed oil, at least oil before bath, and at least 10 to 15 minutes before bath, and then they can take bath. And any soap, as I discussed, any soap as per choice of the patient may be used, provided they shorten the contact time, reduce the lathering, and use an emollient immediately after bathing and soft pad drying. This is like a soak and smear approach. Already prehydrated skin will have an increased absorption and increased effect for the emollient. And the temperature of the water, it should be lukewarm. 27 to 30 degree is the ideal temperature which is recommended. Next slide, please. Okay, next is a major section. This is the identification and avoidance of trigger factors in atopic dermatitis. Identification and avoidance of trigger factors is very important because atopic dermatitis, the course of atopic dermatitis is usually there will be intermittent episodes of worsening or flare, and a periods of quiescence will be there. So in case even a patient is coming with a flare episode, we have to sit with the patient and we have to discuss and ponder what are the trigger factors in each episode. This will be very effective because it will help definitely help in preventing next episode of flare. Because in one patient there might not be only single trigger factor, there will be several trigger factors, but we have to analyze each trigger factor in the patient. And next slide, please. The common trigger factors discussed here are irritants, skin infections, aeroallergens, contact allergens, food allergens, and psychological stressors. And these are all potential trigger factors. These trigger factors can occur alone or in a combination in a trigger episode, in a flare episode. So we have to identify it for a better management of atopic dermatitis. Next slide, please. First, coming to the irritants. That is meticulous history. As I told, meticulous history taking, examination, and relevant investigation should give a logical conclusion, which is the possible trigger. Also, there is another factor. The misconceptions regarding trigger factor should also be addressed, because a majority of the patients which are coming to our OPD, they will implicate food as a trigger factor. Because when they had this food or that food, after that the exacerbation has happened. But we'll be coming to that. We have to address it seriously, because unnecessary misconceptions will lead to several deficiencies, because they will eliminate that particular food from the diet. Coming to the first factor, that is the irritant factor. Next slide, please. Irritants, physical irritants like mechanical irritants like fabrics, detergents, chemical irritants, that is detergents, acids, bleaches, solvents in water. And next are the microbes, that is the biological in nature, infectious agents. Synthetic or mixed or blended fabrics can irritate. For in case in winter and all, wool can be used in an atopic patient, but they should use cotton inner clothes. The ideal one is loose fitting, light colored, open weaved, pure cotton clothes or silk fabrics. These are more suitable. And also it should be emphasized that all the cloths should be laundered before use. They should be washed before first use. That is to remove the chemicals like formaldehyde, which are used in the fabric manufacturing. We give certain practice recommendations. We'll be discussing them. Next slide, please. Next slide, please. Then detergents and other laundering agents. Detergents and other laundering agents, they can act as a trigger factor in atopic dermatitis. It might be used to its exaggerated use or faulty laundering practices, or due to presence or action of various newer additives or components. So thorough cleansing, thorough laundering practices should be discussed with the patient. Sometimes this can cause contact allergy and exacerbation. The practice recommendations are all the fabrics used should be double rinse. Especially the care should be given to the folds, seams of clothes, places where the clothing are snugly in contact with the body should be taken special care. Also, enzyme containing laundry detergent should be avoided. Fabric softeners may be used, but use of antiseptic solutions like Dettol and all, that is a common practice that should be discouraged. Next slide, please. Next slide, please. Other chemicals are chlorine, alcohol, surfactant-based cosmetics, and chlorine. Why I mentioned chlorine is that atopic children also would like to go for swimming and all in swimming pools. This can be done, but we have to ask them to shorten the period of contact, and also they have to take a bath in a fresh water after immersing in the swimming pool, and also they have to immediately after bathing and soft drying, they should apply emollients. All other cosmetics, contents of cosmetics like alcohol, surfactants and all, preservatives, antimicrobial solvents, UV filters in cosmetics. These are all known to cause exacerbate atopic dermatitis in certain individuals. So we have to discuss it with them. And also special mention should be made for the indigenous preparations. Sometimes they'll use some herbal preparations or Ayurvedic oils, indigenous oils. These can also lead to exacerbation. Next is aeroallergenous trigger factor. Common aeroallergens are house dust mite, animal dander, moles, pollen, and all. Aeroallergen sensitization can occur either through the epicutaneous or respiratory route, and this can trigger the atopic march. So we'll discuss when to suspect this aeroallergen sensitization, or when to suspect that aeroallergen is a trigger in a particular episode. Next slide, please. In the mainly mentioned clue is that there will be associated respiratory allergy, and also seasonal clue. That is, the patient will be better in some seasons, they'll get worse in some other seasons. Also, the patient may get better when hospitalized or taken away from their natural environment and reporting exacerbation on reaching back home. Poorly ventilated dam houses, those surrounded by ample flowering vegetation or ongoing construction work, history of any travel and stay at certain localities with abundant pollinating flora, also clinical distribution of lesions over the exposed areas. These are some clues for aeroallergen trigger. So we have to ask about the ongoing any construction work at home, history of travel. These all should be asked during a trigger episode, during a flare episode, to identify the trigger. Now coming to each aeroallergens shortly, short discussion about that. First is the house dust mite. Next slide, please. House dust mite or dermatophagoid steronosis. Now before that, how to establish aeroallergen sensitization. There are no available gold standard investigations for allergen sensitization. Diagnosis should be based on strong clinical suspicion, and this should be supported by atopy patch test, skin prick test, and specific IgE estimation. Often the patient comes with a allergy testing test result. This will show allergy to several factors, aeroallergens, pollen, weed, and all. So we have to sit with the patient and we have to analyze whether there is any, whether there is truly the patient is having trigger due to these episodes and all. So we have to discuss, sit with the patient and analyze the results with the patient. House dust mite, the first one, dermatophagoids Psoriasis and dermatophagoids farinae. The common allergens are DRP1, DRP2, DRP11. The optimal survival conditions of house dust mite are a temperature around 25 degrees Celsius and a humidity of 60 to 80%. Higher concentration of dust mite allergen are found in old single-family homes of lower socioeconomic strata, houses with musty odor, and of higher room humidity. So this we have to so these are all the factors which should be considered when we plan steps for house dust mite mitigation. Next slide, please. So mattresses, box springs and pillows, they should be impermeable to mites and its allergens. Bedding should be washed regularly and thoroughly dried. All the carpetings, upholstered furniture and draperies are to be removed to eliminate reservoir places. So the practice recommendations are, can you please go to the next slide? Control the dampness or humidity. Avoid wall-to-wall carpeting, damp carpets or upholstery. Proper ventilation and airflow should be ensured. Any water leaks, they should be repaired. Spending time in the basements and attics should be advised against. Also in kitchens, exhaust fans should be used. Dehumidifiers may be recommended. And another common practice is drying wet clothes inside the room. This should be discouraged as it can increase the humidity and hence it will promote the growth of house dust mite. Next slide, please. So the encasing of pillows, mattresses are one approach, and physical methods like the clothes, mattresses, and carpets, curtains, and upholstery should be washed in hot water, and they should be dried in direct sunlight. Fabrics, with caution against wet washing, they should be dry cleaned and placed in plastic bags to avoid recontamination. Chemical methods, coming to the next, chemical methods, acaricides may be used with caution, and they can also be used as a chemical method to reduce the quantum of house dust mite allergen. Acaricides like benzyl benzoate may be used to treat the carpet's furnishing. Reservoir mitigation, regular weekly vacuum cleaning with cleaners, HIPAA filters may be used, with special emphasis to bedrooms, mattresses, furnishings will remove the mite allergens. Wet mopping every alternate day with special care given to the corners and crevices should be done. And also encasing of mattresses and pillows has shown to have a result in aeroallergen sensitization. Next slide, please. Now coming to the next, molds and fungi. Alternaria alternata, Aspergillus fumigatus, and Cladrosporium herbarium are the common molds and fungi. They also likely to flourish in the damp environment. So use heating in the winter and air conditioning in the summer. Ensure good air circulation, and any contaminated area should be cleaned with bleach solution to prevent the growth of mold. Next slide, please. Now coming to the animal dander. Animal dander, pets should it is advisable to keep pets outdoors. This will help in reducing pet allergen inside the house. Also, if the pets are to be kept indoors, the care should be taken not to allow them inside the bedrooms, beds, or sofas. Regular vacuuming is advised. Next coming is the pollen. Pollen is another major aeroallergen which can trigger atopic dermatitis. The common pollens are grass pollen, tree pollen, and weed pollen. Seasonality of the disease severity is a clue to pollen allergy. There are several recommendations. In case of pollen allergy, allergy and all, it should be emphasized that complete avoidance is not always possible, but we can give recommendations for exposure minimization. The sensitized individual should stay indoors during the peak pollen season. The doors and windows should be kept closed, and they are advised to take bath, wash hair, and change clothes after coming back indoors. Pollen-proof air conditioning should be done. Use a mask or nose plugs while going outdoors. And lawn mowing or cutting the grass and all, it's had shown to distribute the pollen, and it should be avoided, especially when the atopic child or atopic individual is at home. Or during the peak pollen season. And the pets are one of the major carriers for pollen, so they should be kept outdoors. Now, coming to the food allergy, this is one of the most important topics, not as an exacerbating factor, but one which is always, there is a misconception about the food allergy. The common food allergens are cow's milk, egg, wheat, soy, and peanut. This is usually confused with food intolerance, or rather a dislike to that particular food. When a parent or that is a patient or the caregiver, they're coming with a history of food allergy, we have to discuss it with them. Some they will tell that the child had this type of food allergy only at times. When they are having food from home, they are not having allergy, but when they are taking that, consuming that, for example, chicken preparation, when they are consuming at home, they are not having problem. When they are consuming it from the restaurant, they are having problem. Or at times allergy, actually food intolerance. It is wrongly labeled as food allergy. So what I intend to discuss is what are the cutaneous responses ideally to oral food challenge in atopic dermatitis. It happens in 3 ways. Immediate IgE mediated response, which occurs within 2 hours, mostly within 30 minutes with ingestion of food. There will be urticaria, angioedema, erythema, and the systemic involvement. Second is a pruritus, which occurs soon after ingestion of the specific food, leading to exacerbation of atopic dermatitis. Next is the late phase response, which occurs 6 to 48 hours after consuming that particular food. There will be exacerbation of manifestations of atopic dermatitis, such as itching, oozing, and crusting. That is food responsive eczema. That is what we are mainly dealing with when we are talking about the food related exacerbation in atopic dermatitis. You have to take particular attention that it can occur even 6 to 48 hours later or within a week. So we have to take the food allergy of past week to consider food allergy, to implicate a particular food. So when all we have to suspect all cases of refractory atopic dermatitis, those requiring higher potency of steroid for control of disease severity, and in those with strong classical history of aggravation of atopic dermatitis with intake of specific reacted previously to food with immediate symptoms like urticaria and anaphylaxis. So these are important. All those with refractory atopic dermatitis or those coming with a recurrent flare, we have to take the history and all those telling specifically that each time they are having food allergy, so we have to take into consideration. So how to diagnose? That is, diagnosis should be based on detailed history and recording of the diet of the patient. Character and chronology of the symptoms should be noted. Presence of associated gastrointestinal, respiratory, or dermatological symptoms should be noted. Signs and history of any previous episode of allergy should also be noted. Previous history should be noted. And coming to the testing, food allergy testing should be based on all the clinical history, or we should not randomly give away food allergy testing, because that will always lead to misinterpretation of the results and elimination of particular that is essential foods from the diet of a child. Such as food allergy testing should be ordered only in cases with strong clinical suspicion. Specific IgE test and the skin prick test, they give only results for immediate hypersensitivity. The atopy patch test and double-blind placebo-controlled oral challenge will give results for a late phase eczema reaction. So ideally, what we should do, that is what the gold standard is double-blind placebo-controlled oral challenge. That should be the one to decide which all food to be eliminated omitted from the diet. When in a practical setting, when double-blind placebo-controlled challenge test can be done, because it should be done in a setting where there's emergency facilities for resuscitation and all. If it's not possible, what we can practically do is that we can do a diagnostic elimination diet for 4 to 6 weeks. That is, with a consistent history, we can ask the patient to eliminate that particular food from the diet for 4 to 6 weeks, and we can see for any betterment of the lesions resolution, and we can ask them to re-challenge it after 2 weeks to see if there is recurrence. This is not a double-blind study, but it is a practical thing to do. So anyway, for this double-blind food challenge is the gold standard. That is also the best approach. Next, coming to the contact allergen as trigger factor. This should be considered in all moderate to severe atopic dermatitis, which is persistent or refractory to treatment. Exacerbation on topical therapy with moisturizers or corticosteroid. This should also be considered as a clue to contact allergy to medications. Atypical pattern or distribution of dermatitis, especially with predominant involvement of the head and neck region, hands and feet, eyelids and lips. These should be considered as clues for contact sensitization in atopic dermatitis. Also, treatment of resistant hand dermatitis, which is especially occupation related. The chance for contact sensitization in atopic dermatitis should be considered, and it should be considered as a trigger factor. So the testing and all should be ordered accordingly, according to the history. The common contact allergens in atopic dermatitis patients are nickel, cobalt, chromium, fragrance, balsam of Peru. There is a huge list that is paraphenylene, diamine, colophony, and all cosmetics. That is recent ones like methyl isothiazolinone and all. Also topical pharmaceutical products, as I said, sometimes there will be exacerbation with certain moisturizers or certain topical steroids. So topical pharmaceutical products can also cause exacerbation and contact allergy. Coming to the next slide. Next thing is so coming to the so talking about the investigations in contact allergy. Patch test should be done. Patch test should be done during the remission of the contact allergen in a previous episode of flare. Next is the infection as trigger factor in atopic dermatitis. Changes in the skin microbiome and host immune response exacerbates atopic dermatitis. It has been found that there is increased Staph aureus colonization in atopic skin during the flare episode, and antimicrobial treatment during the flares reduces the bacterial load, and microbes are Streptococcus pyogenes, Staphylococcus epidermidis, Corynebacterium bovis, and Malassezia species. So what are the anti-infective measures? Please, next slide, please. Non-pharmacological anti-infective interventions. The general measures are to maintain the epidermal barrier integrity. That is by proper skin moisturization. Optimal skin hygiene measures, as we have discussed, proper bathing and cleansing. Local hygiene of the eczematous lesion, wet compresses, saline or medicated compresses. And also bleach bath. Bleach bath has got an important role. It's an important non-pharmacological anti-infective intervention. So how do you do bleach bath? And what is the principle behind this? Bleach bathing is adding bleach, sodium hypochlorite to bath water. This has found to reduce the Staph aureus counts and hence the severity of atopic dermatitis and frequency of its relapses. Antimicrobial effect of bleach is based on the property of hypochlorous acid to aggregate the essential bacterial proteins. Patients with recurrent flare due to infection may also be advised to take bleach bath in a regular basis. So how we should prepare the bleach solution for bleach bath? By adding 1 tablespoon of bleach to 1 liter of water, and this should be added to a bucket of water, that is 20 liters. This should and it should be ensured that the bleaching powder has to be completely dissolved in water. There should not be any clumps. Bleach bathing daily when there is overt infection as evidenced by heavy crust and oozing, has found to reduce the quantum of the bacterial load and help in attaining the remission soon. Frequency may be reduced to alternate day later, twice a week and once a week as the condition improves. And it may be also be used as a maintenance therapy in patients with recurrent infection as a cause for flare. This can be used as a maintenance treatment to prolong the remission period, as a once-a-week bleach therapy may be advised. Now, coming to the last one, psychological interventions. Psychological stress, that is, atopic dermatitis is actually a prototype. It may be considered as a prototype for the psych-skin link, because it has been shown that psychological stress can alter the permeability of barrier homeostasis and stratum corneum integrity. Hence, it has been reported that exacerbation of atopic dermatitis occurs in 30% of the patients following stressful situations. In a patient with atopic dermatitis, scratching may be due to a true itching sensation or may be due to out of habit. Psychological interventions and behavioral therapy in atopic dermatitis have proven to improve the remission period and has proven to break the itch scratch cycle. We'll discuss it further. Next slide, please. Visibly disfiguring skin lesions of atopic dermatitis is a cause for stress, especially in the formative areas of years of childhood. That is, when a patient is having skin lesions, he will be bullied at school. He'll be kept away. He'll be asked to sit in a separate bench, separate place, and all. And this will lead to a stress in the child. This stress can further exacerbate atopic dermatitis. This resulting in a vicious cycle. Stress will exacerbate the atopic dermatitis, which will in turn further increase the stress level, and this will be a cycle. So this should really be addressed. Mood disturbances, anxiety, depression, these are all due to increased serotonin levels in patients with atopic dermatitis. There is also an increased risk of developing attention deficit disorder or autistic spectrum of disorders in atopic children. Next slide, please. So the psychological assessment should begin from the first visit. We have to assess the child. That is, when the child is first coming to the OPD itself, we'll have an idea of the general demeanor of the patient, how the patient is, how is he depressed or not. We have to assess that. We have to build a rapport with the patient by sitting with them, by spending few minutes in the first visit. We have to spend some time with them and have to build a rapport. Initial assessment and interventions should always be done by a dermatologist itself. The initially, if you are referring the patient to the psychiatry or psychology, it will give an ill feeling to the patient. It has been found that there will be some kind of stigma going to a psychology or psychiatry department. So ideally, it should be in a psychodermatology dermatology clinic. But if it's not there, we have to address the patient. We have to sit with the patient and discuss with them their problems. So habit reversal. I am giving a short discussion about the habit reversal in atopic dermatitis. Habit reversal in atopic dermatitis. Before discussing about that, in case of atopic dermatitis or in case of any other itch, initial relief of itch is by scratching, and later this is reinforced. That gradually this itching becomes habitual. That is, they have some relief, that they have a good feeling on itching. That is, this itching becomes involuntary and automatic. It will not always be associated with that is itching. Itching will be there, and it will not always be associated with the scratching. Scratching becomes involuntary and automatic. Scratching becomes a habit. Without even itch, the patient will start to scratch. And this habitual itch, it is an unconscious and automatic response. And we have to identify this habitual itch. And aim of habit reversal therapy is to make this habitual, that is unconscious act of itch. We have to make it conscious, or we have to discuss with them. That is whether there is really there is itching is happening, or every time is it are they scratching really due to itching, or is it due to out of a habit they are scratching. So we have to identify this, and we have to instruct a behavior change, and this should be further encouraged by positive reinforcement. Can you go to the next slide, please? First is a registration of the scratching behavior, and this should ideally be started in the second or third visit. That is, after we have started the pharmacological treatment, we have to sit with the patient. That is, at that time they will have some kind of a relief. So we can now discuss about their itch, the severity, at what all times they are itching, how do they scratch. That is, are they scratching with their nails, or are they using some other thing to scratch their skin? What is their feeling after scratching? Sometimes they'll get a instant relief after scratching, or is it a regret that they have broken the skin, or they have caused a break in the skin and an excoriation? What are they feeling after scratching? So we have to discuss it with them, reasoning at what all times scratching is due to itch. Sometimes the patient this should be done after patient has got some relief from the flare. So we have to ask them whether they are scratching when they are watching television, when they are studying, at what all times they scratch without any itch. That patient should be made to distinguish the itch sensation and the scratch behavior. They should be advised to keep a count on the number of scratching episodes per day using tally counter or a prayer counter. This might be difficult when we hear it for the first time, but it will come easy with further discussion and further discussion with the patient. During the next visit, the patient should be given instructions on how to replace the undesirable behavior of scratch by another behavior. So when they are watching TV, or when they are studying, when they have an intense urge to scratch the skin, we can ask the patient to cleanse the fist for 30 seconds with arms placed in a comfortable position at the side of the body. Or if the impulse to scratch doesn't go away in these 30 seconds, the patient may be asked to gently pinch or press a fingernail to the area that would have been scratched. So this should be done with several positive reinforcement. Periodic follow-ups should be done, and encouragement should be done from our side. In such situations, it will work very beautifully, this habit reversal therapy, but it should be done with some kind of practice. All the interventions should always be kept positive, especially in a child. Reprimanding the child, that is, stop scratching, don't scratch, this all usually gives a negative impact. When we see when the caregiver should be given advice that when you see your child scratching, we have to talk, play, and divert the child's attention from the scratching whenever they are caught in the act of scratching. And don't scold them, or don't scratch, stop scratching and all. We have to divert their attention. Periodical stress management sessions, group therapies, and counseling sessions can also be included in the psychological intervention. But the patient after this, the patient has to be referred to a psychiatrist for any drug therapy, or also further counseling sessions later, at a later date. Initial intervention may be done by us, and at a later date we can, after gaining the confidence of the patient and the caregiver, we can ask them, it's better you take a specialist care for this, because the child is having some problems. Then at that point, the parent and the patient itself, they will be willing to go for an expert management. So we can manage them with a combined approach of the psychiatrist and psychiatry side from our side. It is better done in a psychodermatology clinic. Without that, we can involve the local psychiatrist or the psychologist in our institution. So that concludes the non-pharmacological interventions. I have discussed briefly, due to the constraint of the time, I have discussed briefly the non-pharmacological treatment of atopic dermatitis. So I have to to conclude, I should say that it's always complementary to the drug therapy. It is not to be done alone. It should be complementary, but it's as important as the pharmacological treatment. It needs commitment and dedication, but it will give very beautiful, gratifying results if you are practicing it really well. Thank you. And Crichton, sir?
Please go ahead with the questions.
Yes. Yes. Now coming to the questions. I have prepared 4 questions based on this talk. Can you please go to the next slide?
Naveen? Naveen?
Yes.
Naveen, the screen is not shown.
Sir.
The screen is not visible. Please show the questions.
Mr. Naveen?
Doctor, am I audible now?
Yes,
Yeah,
yes.
yeah.
Yes. In between, I lost connectivity. 1 second.
Okay.
I'm not sure. Am I visible?
No,
No.
no.
Second.
Yes,
Yeah.
the first question is, it's a case-based question. 9-year-old boy is coming to your OPD with moderate to severe atopic dermatitis. They are presenting to you for the first time with a depressed demeanor, poor scholastic performance. What will be your best approach at this visit? A, medical management of atopic dermatitis is a one-to-one discussion about the disease, to psychiatry if needed at a, and a plan for referral to psychiatrist in the next visit.
Yes, ma'am.
Yes, can I go into the next question? May I?
Yes, ma'am.
Yes. Are we discussing the answers later or?
No, later.
Later. Okay. Can you show
Second
please?
question.
Second question.
Ma'am, second one. Visible, ma'am?
No.
Network issue.
Yeah.
Second question. This is also case-based. A 10-year-old girl with moderate to severe atopic dermatitis with a history of probable exacerbation following intake of egg. Best approaches: A, advise food allergy testing, especially specific IgE. Advise to exclude egg from the diet. Advise to eliminate egg from diet for a period of 4 to 6 months and then review. D, double-blind, placebo-controlled food challenge.
Yes, ma'am. Shall we go next, ma'am?
Yes.
Yes, ma'am.
All except the following are proven trigger factors for atopic dermatitis. A. Psychological stressors. B. Impetigo. C. Application of medicated oils. And D. Intake of analgesics. So,
Yes,
can we
madam.
go to the next
Shall we go?
question?
Yes, ma'am.
Yeah.
Next question. Yes, ma'am.
What are the optimal survival conditions of house dust mite? A. Temperature around 38 degrees Celsius and humidity 40 to 50%. B. Temperature around 25 degrees and humidity of 60 to 80%. C. Temperature around 10 degrees and humidity 40 to 50%. D. Temperature around 40 degrees and humidity of 60 to 80%.
Yes, ma'am.
Okay. Thank you all for the patient listening. I'm sorry there has been some interruptions in between. Captain sir?
Okay. Okay. Of course, there are some interruptions, but the talk is good. The content is also good. Of course, we usually forget about the importance of non-pharmacological interventions in atopic dermatitis. And every time when the atopic dermatitis child comes, we straight away go to the pharmacological interventions and persist on that. When at the same time, the importance of non-pharmacological interventions are forgotten. But the talk gives a very important message that along with the pharmacological interventions, non-pharmacological interventions must be done. But of course, it requires a lot of time and patience on the part of the caregiver as well as the patient and their relative. The relatives as well as the patients require immediate cure and immediate response. But that may not be as easy as one should think about. So we have to educate the patient as well as the caregiver about the prognosis or about the path of atopic dermatitis and then introduce the treatment along with non-pharmacological interventions. And the non-pharmacological interventions should be considered till the end of the treatment. So anyway, this is a very important practical aspect of management of atopic dermatitis. So please study the non-pharmacological interventions in detail, which will help you to be a good practitioner. So thank you, Dr. Geethu, for your wonderful presentation. Thank you all.
Thank you, sir.
Sir, the winners are ready, sir.
Yeah.
Yes,
Go
sir.
ahead.
Yes, sir. The first, the previous session, the first question winner is Dr. Mithun K. Manoj from Pariyaram Kannur Medical College.
Okay.
Dr. Mithun Manoj.
Okay.
And the second question, the winner is, the name is not mentioned, Samsung G781B. Doctor, are you there, doctor? Samsung G781B. Doctor, are you there? Samsung G781B. Doctor, may I know your name, doctor? Your name and medical college? Kindly type it, doctor, or else you can tell orally. And in between, the third question winner is Dr. Anand Matikopa from Vizag Medical College. Yes, doctor. And the third question, the Samsung, the doctor name is Dr. V. Sushmita Dhanlakshmi Srinivasan Medical College. It is at Trichy district. Dr. Sushmita from Dhanlakshmi Medical College. Okay, sir. Okay. And the fourth question winner is Dr. Ramesha. Dr. Ramesha, are you there, doctor? Dr. Ramesha? Dr. Ramesha from Andhra Medical College. And Dr. Ajay G. Dr. Ajay is for the fifth question winner. Dr. Ajay? Doctor, sir? Dr. May I know which medical college you are from, doctor? From Andhra Medical College. Okay, the fourth question and the fifth question both are from Andhra Medical College, Visakhapatnam. Okay, sir. And the last session, Dr. Geethu ma'am session, the first question winner is again Dr. Ajay from Visakhapatnam Medical College. And the second question winner is Galaxy A225G. Doctor, may I know 225G? Galaxy A225G? Galaxy A225G? Dr. Melita. Dr. may I know from which medical college you are from, doctor? Dr. Melita? From Pariyara Medical College. Okay, doctor. From Pariyara Medical College. Fine. And third question winner is also Dr. Melita from Pariyara Medical College. And the last question winner is the name is mentioned iPad. Doctor, may I know your name, doctor? iPad. Doctor? Dr. Shakti Ujwala. The doctor, you are from which medical college? Doctor, from which medical college, doctor? Dr. Shakti Ujwala. Dr. Shakti Ujwala from Sri Mugambike Institute of Medical Science from Nagarkol. Okay, doctor. These are the winners. Yes,
Okay,
doctor.
congratulations to all the winners. You will receive the prizes from West Pharma.